Well, it is 12 o'clock, so we can get started. Thank you, everyone, for joining us. I'm Tanya Lauder. I'm the Director of Finance for CFHA and also have the privilege of co-facilitating the community conversations, which is fairly new. It's been around for a year and a half, almost 2 years, but a place to gather and talk about important topics to all of you that are practicing in the field or associated with integrated care. So we are glad to have you here today. We're excited about the topic that we've been able to, that Andrea and Neftali are bringing to you today, specific to the state of Georgia. So I will turn it over to our CEO, Dr. Neftali Serrano, and welcome and thank you.
Yeah, thanks, Tanya. And I'm just going to set the stage and move out of the way as quickly as possible here for Andrea, who's really the star of the show today, and Resilient Georgia. This is really exciting for us at CFHA because one of the things that is clear to us in terms of moving the field of integrated care forward is that we are past the point of convincing people in general about the importance of integrated care. Everybody thinks integrated care is a big deal and is an important thing. CMS does, Department of Human Services does, HRSA does, many state entities, state departments of health do. So we don't need to convince people anymore that integrated care is a big deal, that it's important for the quintuple aim, that it's important for both the economics of the healthcare they're providing as well as the quality of the healthcare we're providing. We don't have to do that baseline work of convincing anymore. Now, when we get into the nitty-gritty of making things happen, it comes down to states and sometimes even local regions where things have to move in order to enable really good people like many of you to do the good work you need to do to care for patients as whole people. And so when we were approached by Andrea and Resilient Georgia to say, hey, is there something we could do to help the good people, the good professionals in the state of Georgia to move this forward, we were like, yes, absolutely. We chose the format of a community conversation because we wanted to start off a little bit broader and get a lot of input from folks before we kind of morph into something more of a work group. So that's the format of today's conversation. It's going to be an opportunity for you all to inform an agenda, to give us some thoughts and ideas. And after this, Andrea and I will get together and process and think through what some tangible next steps might be to actually move things forward. We definitely want to be action-oriented. This is not just a conversation that will die today, right? That's not the intention at all. The other piece of context that's just helpful is just that we've had some success with things like this in the past. There's a group that we also sponsor in the state of Tennessee that has come together, and they've met with legislators. They've introduced some of the barriers that they have in the state of Tennessee related to integrated care, and have successfully, at the very least, garnered some champions within the legislature to work with going forward. So, there's some good evidence that when you do organize and when you have a collective voice, you can really move things forward. And as we all know, I live in the South here, or at least as South is, if you think of North Carolina. The South has a lot of work to do. There's a lot of opportunity for growth. So I'm excited about that, both as head of CFHA, but also as a citizen of the South. So without further ado, I'd like to pass it off to Andrea, who's going to help lead our meeting today. And Andrea, take it away.
Wow. I have to admit, I'm a little nervous, y'all. Some of my favorite people are here. And I don't know about you guys, but when your favorite people are listening to you talk, it makes you even more nervous. But I'm just really grateful to see so many faces I know and so many folks I hope to get to know better. I'm going to introduce myself, but also I'm going to talk a little bit about Resilient Georgia and how we're connected to this hopefully growing collaborative or group or work group in terms of our mission and our aim as an organization. So I'm not going to bore you with a PowerPoint because, again, we're all here for one reason, which is to move this forward. But I do want you to have the information, so I've included it in the chat, and you can also go to our website resilientga.org to learn more. If you're not aware of Resilient Georgia, we began about 4 or 5 years ago, right before COVID hit. We are an organization that is working across the state, combining our public and private partners and different stakeholders to work towards a more resilient and trauma-informed Georgia by preventing adverse childhood experiences and promoting resilience. Our primary mission is to lead that statewide public-private partnership in an effort to build a more closely aligned and trauma-informed network for birth to age 26 in terms of an integrated behavioral health system. And even though it's birth to age 26, we know when we're working towards integrated care for 0 to 26, it's really for anybody that's part of that person's life when you're thinking from that perspective. So we mostly have worked across the state with building coalitions. So we have 16 regional coalitions that we work very closely with. Actually, I was part of one of the first funded coalitions in Middle Georgia. And we have on our website a list of all the regional work that's happening. And I would really encourage you to get connected with your regional coalition as well if you haven't done so already. We're involved in over 120 out of the enormous number of counties that we have in Georgia. We have 159 counties. So we have a wide reach across the state, and we value that we're reaching outside of Atlanta to the other parts of Georgia that are just as important as the major metropolitan areas. And we're really trying to align the work across the state. One of the main jobs I have in my new role is to advance the workforce through recruitment, retention, education, and development. And so that's what brings me to this place. And to be honest, the past 12 years of my life have been in education and academia and training MFTs to go out and offer medical family therapy and integrated behavioral health. To sadly witness that many of those could not find jobs in that work. And, you know, I see, and we all know the benefits of integrated care. And it's very frustrating when you see really great clinicians who have a passion for it not be able to take that passion and really go out to the community and do the work. So I'm really lucky to be able to drive the next steps at Resilient Georgia towards thinking through what are some of the ways in which we can advance our mental health workforce across the state. And one of those ways is through integrated care. And I'm very, very lucky to have been educated over the last 10 years at CFHA about how important the work is. So that is me. That is what I'm here to hopefully facilitate today. I see we are gaining more and more members. So I'm wondering, Neftali, if we want to do intros of those who have their cameras on, who want to introduce themselves. And maybe if you don't want to introduce yourself visually, you can put it in the chat. Oh, look at that. We have more cameras turned on. So I'll just start by naming some folks. Do you think we have time? Or do you want to do just the chat?
I would suggest chat for a group
Okay.
this size, to be honest.
Okay. Okay.
Yeah.
Well, I can, so let's go ahead and take a moment in the chat to introduce who you are, maybe where you're working or and what kind of work you do in that setting. And then we'll give everybody a minute to do that. Do we have the elevator music to play
Uh,
while that happens?
you know, you don't want to hear me hum. But as you're putting in your things, I will let you know this will be a very participatory session. So just so you know, I don't know, people sometimes get surprised when we do breakout groups. So we're going to be breaking out into groups here, and you'll get a chance to talk in small groups, and then we'll come back together as a large group and share some of our thoughts as we start to think about what's going on in the state of Georgia.
Great. All right. So I know we have some folks that are, we have a student, we have some folks working in FQHCs, we have some physician folks, we have some higher level folks in education. So we have a good diverse group here, which I think will help with our conversations.
Absolutely.
Yeah. So we have developed, and I'm going to let Naftali talk about the questions now. With some support from AI, we developed a list of questions that we thought could get conversations going. And so I'm not sure if everybody has them in the chat, because if you joined after, we might need to repost them in the chat.
That's fine. I'm gonna pull it up.
Okay. Okay. So what we thought we would do for the next part of our time together is well, first of all, give you a chance to look through the questions that we thought could guide our conversations. And Naftali, do you want to talk through the different questions and get us going there? Okay.
Yeah, so there is obviously a lot we could focus on if we think about what really needs to drive things in integrated care. And today's discussion can take us through all of these or some subset of these. So I'm going to take you through the different categories, and then I want you to be thinking about which category you might want to kind of join as a breakout group. Because I'm going to ask you in a moment to put in the chat which group you might want to belong to, just to get a gauge. We don't want somebody to join a group and there's only one person in that group, right? So then afterwards, you're going to have an opportunity to actually formally select which group to go through 1 through 8. So the first possible subgroup we could talk about is really just what's the current state. So where is integrated behavioral health in Georgia's primary care settings currently? And are there some exemplars, for example? Those would be some particular things to kind of talk about if you're in that subgroup. Barriers to adoption. So what are the main things that have gotten maybe in your way or in your students' way or your workforce's ways in terms of implementing integrated care? Specifically, potentially you could say, what are potential financial models that you've seen work, or is it a lack of financing and reimbursement that perhaps is one of the issues? Also, you can think about regulatory issues. Are there things that are regulatory related that keep integration from occurring effectively? The third group would be best practices and models. So are there particular models that you've seen to be best suited or proliferate more? Are there issues with that implementation of specific models? And is there technology, exemplars of technology and how those are being used to overcome barriers? The fourth group has to do with workforce development. So I've got lots of thoughts about this group for sure. Education and training of healthcare professionals is how does the workforce get filled? Are there pathways? Are those pathways seamless, or are there difficulties with folks moving through the ranks to fill positions in the field? The fifth group would be the patient perspective. Do the patients have a voice? Do they know about integrated care? Do they need a voice? What might be ways we engage patients and communities in designing integrated care in their communities? The sixth group would be really about partnerships. So who are the primary stakeholders? Who are the people and organizations that are crucial to bring together to move things forward with regard to integrated care? Who are the power players in Georgia that could make things happen or keep things from happening? The seventh group would be any innovations. So are there innovative approaches to integrated care that could be explored in Georgia? And what do you think in the next 5 years would be the best innovations to move integrated care forward? And then the eighth group is more sort of like if you're good at like planning stuff, this would probably be a good group for you. If we did form a work group, what would be the key objectives and priorities that you think would be best for a work group type format? And what kind of dialogue could that work group engage in and work in? So those are the 8 groups that we came up with. What I'd like you to do now is try to put in the chat you can put the number of the group in there, what group you think you would be most interested in talking about. So we've got some folks putting in the couple of 4s and a 2, 5 and an 8, another 8. Yeah, keep them coming. Some more 4s. Okay, so we definitely have plenty of 4s for a group. We have plenty of 8s for a group. And a couple of 2s, 1 6. All right, keep them coming. If there's anybody left, is there anybody left who has not voted, just still mulling it over? Some indecisive folks. I know there's lots of things we can talk about, and I promise you we will talk about it in a large group format. So don't think of this as your only opportunity to kind of chat about the particular topic. Okay, we've got enough 2s, we've got enough 4s. We have enough, let's see, we've got enough 8s. And we've got 2 6s. One 7 3. Okay. If that is everyone at this point, yeah, let's see. Okay, so how about we do a group 4? So group 4 is the training and education. That's exciting. That's an important group. A group 8, which is kind of planning for a work group and what a work group could focus on. Looks like we can do a group. Let's do a group 6. And so that is collaboration efforts. Yep, that's partnerships and who would be the key players to include there. I think that's what we have so far. Okay, so we've got those 3 groups thus far.
Maybe should we add 2? That was a big one. Barriers.
Yes, we can do a group 2 as well. It might be a small group, but that's fine. Okay, all right. Now, Liana is going to put up the breakouts. Just choose the group of your choosing. And hopefully no one ends up in a group by themselves. And then we're going to give you, was it 15 minutes, Andrea? So 15 minutes in your small groups to kind of discuss the questions. Then we're going to come back into the large group and discuss together.
Alrighty. You all should receive a little pop-up, and you can pick from those 4 groups. Welcome back, everyone. I hope that was a smooth process.
Welcome back. We were still talking when the timer kicked us out. So I think that is a good sign. Naftali, I'm wondering, do we want to start with the groups? Do we want, I thought it was interesting. Sorry, I'm all over the place that nobody picked number 1, which is the current state of integrated behavioral health in Georgia. I feel like we have to have that conversation at some point to move forward. So we could do that after we just do the discussion of the groups, or now. Naftali, what do you think? Either.
Well, yeah, why don't we have that conversation now and then have the report outs?
Okay.
And that can actually dovetail with report outs, because the group I was in was group 8 around the work group,
Okay.
and we did talk some about the current state as part of that
Okay.
conversation, because obviously a work group would be oriented towards that. But yeah,
Okay.
let's open it up to everyone to just kind of share your thoughts. You are on the ground, you are seeing and feeling things as you try to build programs, as you try to move the needle. What is the current state of integrated care in the state of Georgia? Where do you see perhaps some exemplars that we could point to, or perhaps some of the almost theirs, we'll call them. Almost there, but not quite there, related to the current state. So if someone asked you, like I am, what's going on in Georgia with integrated care, what would you say? And feel free to unmute yourself.
I think from my perspective, I work in such a bubble that I don't have an awareness of what it looks like outside of Athens. I can tell you what it looks like on campus and maybe a bit around Athens, but honestly, I'm not sure what that looks like outside.
Well, actually, that was, Hannah, one of the things we talked about in our breakout group, that there doesn't seem to be interconnectivity between the disparate individuals and organizations doing different forms of integrated care across the state, which itself could be an objective of the work group, right? That was the context we were thinking of it, to bring these folks together for different kinds of purposes, information sharing, advocacy, and just creating sort of a level setting the state related to that. However, also with that, Hannah, maybe you could tell us what is going on in Athens and in the area that you know of as a way of kind of moving that needle.
Sure, absolutely. So I work at the health center on campus at the University of Georgia, and we have an established collaborative care model that's been around for maybe like 5 or 6 years, and so this is open to all students and their dependents on campus, and we work a lot with providers outside of campus, and there seems to be a big saturation of mental health care, and so it seems like there's a lot of resources in Athens, and especially for those who are insured. For those who are not insured, we have a great community health center as well. But yeah, so that's what we have. We have a lot of psychiatric providers too, and so it seems that's pretty much where we will refer students, rather than primary care settings if we're referring students out from the health center.
Okay. All right, so we have the current state from Athens, at least. How about elsewhere?
Hi, this is Chase Gross. So, first of all, I'd love to be one of those contacts. So I'm the chair for GPA's Integrated Health Committee, and we can talk about that later. But there seems to be a few places that do this well, like Wellstar Health System and Children's Healthcare of Atlanta. There's a place in Augusta. I'm the only psychologist working in my system, and I might be the almost there person doing integrated care. So the other thing is how do we reconcile the collaborative care and integrated behavioral health model? And they I think it's probably an and both situation, but it doesn't seem like that is really been panned out, even though I think psychiatry kind of has a foothold in pushing forward the collaborative care model.
Yeah, that's actually one of the other themes that our group talked about related to the current state, that there's not a lot of clear understanding across the state around the definition of the models, and then what you're bringing up, how they actually work well together, is not a great understanding of that. So in your case, you're talking about PCBH and collaborative care, but do people understand those terms and understand discretely what those two models are trying to accomplish, right? It doesn't seem from what we talked about that there's a really strong understanding across the state around those things, which also makes sense why it seems like there's not an understanding of who's doing what across the state, right? Yeah.
So I'm Monica from Cobb County, and I've been in the space for almost 12 years. And Wellstar, I agree, has more. They have about 110, 120, give or take, doctor's offices that they own. And my last understanding is that they have 5, 6, 7, 8 that they call, give or take. Again, this is old data that they call integrated healthcare. So that is an outpatient. However, the big however is, and children's does that too. However, when 911 calls happen that are behavioral health or substance use related, we are told repeatedly by our first responders, they don't want people to be dropped off in ER. Like ERs are saying, do not bring them here. And so that where it's missing really is in the ER, because that's your point of entry. For many people that you and I are trying to talk about, the point of entry is 911. It's not taking my child to the primary care physician and saying, you know what, she's not being eating. I mean, that's the certain population is going that way, that route. Bulk is entering very wrongly, very incorrectly, and ending up in a mental health dumpster called ER or the jails.
That's
and
right.
So I think that as a community, as a coalition, we have to tackle that. Because otherwise we are catering to a small population that is insured and knows the concept of behavioral health and goes to these 15, 20, 30 clinics across the state. We are missing a huge population. The second thing we want to say in line with Clark, with Hannah, is Kennesaw State University, which is the third largest university in the state of Georgia, has made a humongous effort for integrative healthcare. So we have a student health center, but we have a whole coalition focusing on student mental health and well-being. And this whole coalition of 20 plus people, and Hafiz is part of that, we make sure that the student health center as well as the behavioral health counseling center are best friends, and they really take care of the whole student. So campuses based on COVID money, at least in Georgia, I think the 29 campuses have become a little bit more integrated than they were pre-COVID. So that's good news. Community is not like that.
Right. You guys are mirroring our group's conversation so much. We had Mr. Johnson, RJ, at talk about first responders and their needs, not just like their patients' needs, but their needs for integrated care as people witnessing vicarious trauma. And then you're bringing up what my wife experiences on a daily basis. She is an emergency medicine physician. So very well aware of that as a huge entry point for the potential for integrated care.
Yes.
I also want to mirror Courtney's comment in the chat. That one of the things that I would want to coach us all to do is not look at just the veneer, because what we've found is a lot of times there'll be a veneer of integration and not when you dig in and you actually get into a system. And in my case, I've spoken with the person who directs the WellStar integrated care piece, and that is much more at its origins than it is in any form of mature development there, right? But it's still important to point out that there's at least systems who are trying to pour money and effort into these efforts, but whether those efforts are mature or not is sort of a different story. So that's just part of the conversation.
I wondered too if some of the Augusta folks who are here might want to pop in for a second since they were mentioned by Chase. Did you want to share?
I can share, and Tiffany Snow, my counterpart, please chime in as well. But Chase, I believe we're the agency in Augusta, Georgia, Christ community that you're speaking of, that we pride ourselves on being fully integrated. As you guys can see, a lot of things are going on around me. I'm literally positioned in the middle of the clinic. We operate on half standalone visits and then half warm handoffs. So I am ready and available at any point in time for a provider to come and pull me into a room. A lot of what I do, from the support of Dr. Serrano, who really has been with Christ Community since inception, about 2018 or 19. He really broke barriers with parsing out, specialty mental health care versus building the core framework for integration. So everything that I do, I try to do it in a span of 30 minutes. I try to ensure that I'm doing constant collaboration with my PCPs. We're in constant communication. We use the same EHR. We're in the same building. We're right down the hall from each other. I use the same room. So I think, to your point, I think a lot of agencies may speak of integration, and I think we all conceptualize that differently. But from when we really study the models and think about the goal of it, it really is for this fully integration, close collaboration. We're all using the same systems. We're all in the same beat and flow together. So I think, Tiffany, you can speak to how we've done that on the pediatric side. I'm the adult provider and manager.
Yeah, definitely. I am over in the pediatric side. And we've recently added, we have a psychiatric nurse practitioner. So we have a flow, not just for the PCBH flow, which is what Carol described. I am literally in a patient room right now because I don't have an office. I don't need an office. I'm out there where everybody else is. I'm in the flow. I'm popping in rooms, and it just, communication goes pretty fluidly. We use a chat. If we can't get each other in person, we have a chat that goes, so we're constantly in connection with one another. But then we also have a flow where we're trying to follow also like the collaborative care model. So we have a flow for our psychiatric nurse practitioner. If we do need like more diagnostic clarity, if we need more complicated medication adjustments, and so we have that as well. So we kind of have the two models, and we're in a process where we're still kind of figuring out that flow. But it's like a good kind of problem. It's a good kind of thing that we're trying to work out. And so far we just adjust day to day. We talk about things as they come up, and we're just kind of making it work.
Thanks, y'all. I just realized if we want to hear from all the groups before we need to leave, we might need to shift to reporting out. With y'all's permission, I'd like to start with group 2, barriers to adoption, and then we'll move towards, 4 and 8? Were those the other two? Did I miss one? 6?
6.
Okay. So group 2, I was in group 2.
Sorry to interrupt. No one ended up meeting in 6. It was just
Okay.
2 for 8.
Okay.
As far as
Thank
people
you.
in groups.
I thought there were 4. I knew I could count, but
Yeah, no, there were for 4 groups, but no one
We'll
joined
get to
6. So yeah, you're fine.
maybe we'll have a little more time. And again, this is just the beginning of our conversations. We could spend our whole hour and a half on just one of these set of questions. So And we will come back if we need to in future meetings. So group 2 was myself and Morgan and Chase and Bowden and April. Do one of you all want to, I wrote down notes, but do y'all want to summarize kind of what we came back with from our barriers conversation?
I can talk, I guess, since I talked a lot in our group. The main things that we came up with as barriers has been difficulty engaging people in the process, whether that's physicians, leadership. It's still, even though we're saying people know that it's a good thing and we need it and the outcomes are better, it's still sometimes difficult to engage. There's also a disproportionate amount of resources going to crisis stabilization and management rather than prevention and catching things early. There's a lack of collaboration among different agencies, specialties. You know, some people can get reimbursed for behavioral health services, other people cannot. You know, there's a lot of nuance and difficulties with that because of how our system is set up. And then there's a lack of understanding and a way to be updated on ways to financially sustain and integrated behavioral health. There are lots of options out there, but not everybody knows about it. There's no like centralized way. And for someone like me, you know, I do pediatrics, it's all Medicaid, but it's different for every state when you do Medicaid, right? So what does Georgia offer and how do we get paid for things? And some people are doing it well and others are not. And then a lot of the weight of what's happened has fallen on primary care, which is really undervalued, right? It's just the specialists get a lot of attention, primary care, who's bearing the brunt of this and really trying to make this work is just not being seen as the valuable asset that they are. So those are like the biggest barriers I think that we came up. Did I forget anything, you guys? I don't know. You guys chip. Yeah, okay.
Well, I wrote 2 other things down. One was the low rates of reimbursement. So in Georgia, the rates of reimbursement are significantly lower than other states. Resilient Georgia is part of conversation about that piece. And also, not to call you out, Chase, but you had mentioned something about same day billing and tax IDs. I don't know if you want to share what that was.
Yeah, so it's, you know, when you have multiple services in a clinic like ours and you don't have separate tax IDs, the billing is going to default to the PCP. So it's sometimes difficult to get your services or a mental health provider services paid for. So kind of how do you address that? And then you end up taking more and more kind of individual therapy patients to sort of build up that revenue stream, I suppose. So, yeah.
So just to ask that, because that's a very common question that we've been chipping away at state by state over the years. So do others also have that same experience of the lack of support for same day billing across different payers?
I will say I've experienced a few times that it hasn't been universal, but it's rare and it's almost like the biller thinks that this was a fluke. But I'd have to go back and see which carrier was put that through.
Okay. That might be some of the fact finding that a group work group works on.
Were there other barriers folks wanted to mention that weren't mentioned from our group?
I want to mention really quickly, because I know we have to have time for everything, so I'll talk like the Micro Machine commercial guy. But what I see, I think just in primary care in general, especially in the rural areas, is retention. I'm not talking about behavioral health. So it's just like, it might be, our organization, and yes, like morale always can be a thing, but like retaining good providers, I don't care who you are, in these rural areas, their shelf life is probably a year and a half, and then they're gone. And so it's even harder to have a behavioral health person in those areas. And then once one person leaves, there goes your champion. And then, you're starting from scratch. So it's like, how do we, and this is, many disciplines, how do we retain people, not burn them out? Because like Dr. Hartman was saying, it's like the more burden gets placed for productivity, especially primary care providers do everything, you're going to get burned out, and you just can't take that. And so it's just, it really affects it if you don't have a solid pipeline, like a teaching hospital or when you're in the rural frontiers, we're struggling of like, oh no, now we lost two medical assistants and a PA, and then the physician. And so it's like, oh no, what do we do? So anyways, so retention is, I think, a barrier.
Thank you. Yeah, I mean, I think as a system, if you are losing everybody, focusing on integrated behavioral health is kind of not in the forefront of your mind. It's just getting people to be there to provide services, period, can be a challenge. All right. So we have, and if you think of anything while the other groups are talking that you want to add to the barriers conversation, please put it in the chat. I assume we'll have access to the chat records and we can kind of coalesce information from there as well. So our next group was group 4, the training and education. I don't know if you all, voluntold someone to share, but who would like to share from group 4 about what you all discussed in that time period?
I can jump in. We spent a lot of time just getting to know each other and seeing what settings we were working in, and it seems like they're just very different. And so we probably had 1 minute to talk about the actual prompts, but the participants, we started sharing. So if anyone wants to share, go for it.
Brian?
Sure. Thank you. One area that we believe it would be a great need, and particularly for maybe a work group, I don't know if it's the work group, but maybe a work group, would be looking comprehensively at all of the degrees and licensures, as well as the graduate work and dissertations that are involved in this area at every university throughout the state of Georgia. And then juxtapose that alongside with where the gaps are, what licensure and what types of programming are happening in the state. We believe that would present an opportunity for us to really focus in on what education needs to take place. Secondly, from the conversation from the first group, I believe it's evident that from an undergraduate standpoint, it would be very beneficial to teach our current students in the state of Georgia about the models and the differences of the models, so that they have an idea of what they're learning about and how they can impact Georgians. We work for Regional Comprehensive, and one of our goals is workforce readiness. And so, if we're having trouble at the top understanding the models, you can imagine what that might look like for someone getting ready to enter this workforce. So I think we have a lot of work, but having everyone here, I've learned so much from this group already in this short amount of time. I think there's a lot of opportunity. That's fantastic, Brian. Thank you so much for that. Yeah, I want to go in a 10,000 directions here, Andrea. But one follow-up to that, Brian or others, is how strong your AHEC or AHECs are, as well as they are often, I mean, every state has different strengths in terms of whether their AHECs are strong or not. Do you all know anything about the AHECs and whether they are active players in this space, promoting integrated care, doing training for integrated care?
Our local AHEC doesn't do that type of training that I'm aware of. Most of what we've been involved in is kind of more trauma-informed care, which is also important, but not directly towards integrated.
And Carol, I saw you talking, but you were.
Oh, yeah. I don't believe our AHEC at in the Augusta area provides education, but I know on integrated care, I know I did reach out to them about maybe creating like a CEU and then them helping me be able to disseminate that throughout the state. So I know they're open to maybe some collaboration, but right now it's nothing for us at all.
Yeah, so we're at the national level we've connected recently with the national AHEC. And so that may be a vehicle, but maybe food for thought for you all is if you think about some of the existing channels, right? Instead of developing a brand new channel of education, if we could use existing channels of education to level set and educate at the different levels, right? From the trainee level up through. And again, we're talking not just behavioral health, we're talking about medicine and behavioral health here at the different points of training. If you have some thoughts about that, that would be very important strategically as to where we put our effort and where we might, because we have the education like that's the easy part. CFHA has content experts and different pieces of the education of the different models, et cetera. We can develop curriculum very easily. A work group could help facilitate and we can brand that with Resilient Georgia's stuff on there and do it all up. It's just about strategically how you deliver through channels that people are already potentially getting education from or organizations that are kind of have deep roots.
And I wonder if, you know, using these academic centers to send their students and, you know, one of the things that they're always looking for is places to send students, right? And so to me, it seems like we need to put our students in the practices that are doing that so that they can see right from the beginning. And it's a big deal because I know, you know, I'm affiliated with Medical College of Georgia, and we're always looking for places to send students. There's never enough places. And so if practices would open up their doors and be like, yeah, send a student to us, you know, it may slow us down a little bit, but we're committed to letting them see how this works so much better. I think that's how you get it started. You get a movement started. And one of the things I brought up in our group is that we kind of took a different approach on integrated care. We focused our education on our primary care providers. They all did the REACH training, so they had additional behavioral health training. They all did trauma-informed care training. And we made it where when it comes to doing those brief interventions, they can do it themselves. And they can do it. We showed them how to do it in 5 to 10 minutes. They can do it right then. And it really decreased the number of referrals that we had to the behavioral, because they could take care of a lot of the straightforward stuff themselves until we can get this workforce built up, right? Because we just had a hard time finding anybody. But what we discovered in the years that we've been doing integrated care is that we have a lot less need for psychiatry. Like we understand how to do med management. We don't need someone to do that. That's what we do all day, every day as a general pediatrician, right? What I need is someone to do therapy. And that's like, that is the critical thing. Like, even when we send them to our local community-based mental health center, they'll give you numbers like, oh yeah, we get them in right away. They're doing the assessment, but then they get put on a 6-month waiting list to be, you know, to see a therapist. Yes. So what we need is therapists. Like, we don't need psychiatrists. We can get that part. Give us therapists who can talk to these kids, talk to these people, get them through, because we found that so much of this is trauma, right? And so when you're dealing with that, that's not medication. That's therapy.
So I think
Go ahead. Sorry. Sorry.
that sounds wonderful. That's like music to my ears, right? So I think there's a lot of room for the collaborative care model, yet it is kind of put up towards legislators, and they say, well, that's a great idea, and I want to help people, and yeah, I'll put my name behind this, but I think that you don't get the part that you're missing, right? Which is having a mental health provider in the room to provide that kind of critical, those tools and that skill building. So yeah.
I agree, because we try to place social workers in the healthcare system with Wellstar and Northside, and they'll take one intern, they'll take two interns, and that's it. And that does nothing. That does nothing. When many students want to go into the healthcare system, the internship opportunities are not there. But I also want to say, this is beautiful what you said, April, about integrative healthcare needing, the physicians needing support by clinicians. What we are noticing is we have started, this was about 6 years ago, at the undergraduate level and now at the graduate level, our students have to take an interprofessional collaboration class. Play with each other, learn to play with each other, because whether you work in school systems, in jails, in other human service organizations, you will be playing with many different people who don't walk and talk like you. So it's been a game changer for us. And that is our contribution to integrative health. They have to start seeing each other on campus and not just in bathrooms. And then they go into the workforce. Oh, you're from Kennesaw? Oh, I'm from Kennesaw too. Well, you should have met each other before you went out there, right? So we, in our own way, have made interprofessional collaboration a required class for one of our majors, absolutely a required class. And for training school social workers, we have made that a required class. Because in school social work, you'll be playing with the entire school system. Right? You better play nice with the superintendents and the principals and the janitors to catch this child from every angle. It's a requirement. Just my 2 cents.
That's fantastic, Monica and Dr. Hartman. So a core principle, not to get into education here, but a core principle of the PCBH model in particular includes aspects of what you're both talking about. So obviously this is not at the training, this is at the implementation level, but just to reaffirm that you're headed in the right direction, right? The principle is that the best way we can have impact on the population is not by assuming care of that patient, but rather partnering with the team and enhancing the work of the team in various forms. And one of the principles is cross-pollination. So the idea is that, and just for context, I'm a psychologist. I've worked in primary care all 22 years of my clinical life. I get better at what the physician does with the patient. The physician gets better at what I do with the patient. So that means that my impact is much more than just all the individual contacts that I have with the patient. I actually have enhanced my provider's ability to identify and do some basic intervention with their own patients, do basic decision-making so that we don't have to refer as many out. In fact, the goal of PCBH is to retain about 90% of patients within primary care between the work of the team. So yeah, any solution that we think about has to have that emphasis. Otherwise, we're not making, a large difference. What I love about what you're talking about, Monica, is that when you go upstream with that perspective, then it makes you question, why are we training these professionals separately to begin with, right? Like if they're going to work together eventually, why would we train them so that they don't understand their cultures, they don't understand their language, they don't understand their domains, et cetera, right? And so kind of pointing those things out is I think an important piece of thinking strategically for Georgia around where we could have some real strong impacts. But you have to work across the challenges working across, because Abby's comment in the comment is exactly part of the problem, right? So then we can train someone, but then if there's not opportunities for work once you get out, that becomes challenging. I mean, exceptionally challenging. And Abby, because she was in my group, works in rehab. which has a history of collaboration within its sort of discipline, that is unique, I think, within that realm. So that might be another strength we can tease out within the state, if perhaps we could coalesce the folks in rehab medicine and take some lessons learned there and apply that to other places like the ED or other segments of the healthcare space. All right, off my soapbox.
Well, you connected all three of those comments / ideas together, so that works for me. So I do want to shift to group 8 because I think that's a great kind of finishing spot, which connects back with our agenda of what's next. So would some folks from group 8, which is the forming a work group?
Yeah, so actually I was the default reporter since I was. Yeah. So we've actually talked about most of this stuff already. I'll list them out here. So yeah, there's not a great sense of coherence around the use of the term integrated care across the state. So people mean different things by what they mean by integrated care. So that could be a focus of a future work group, is to help level set some of that. There's substantial barriers for getting buy-in from the medicine side in certain sectors. In particular, RJ was talking about how he's had some difficulty convincing administration to integrate care for first responders who are dealing with vicarious trauma, et cetera. But in general, that idea of medicine's buy-in. And so the take home from that was, if we're going to have a work group, it has to have medical representation in order for it to be effective, because the champions have to come from the medical side as much as from the behavioral health side. We also talked about billing and billing advocacy as an issue, both the amount of reimbursement, but also the access to codes like LPCs, LMFTs, LCSWs, at least for Medicaid, do not have access to the health and behavior codes. So that is a barrier that the work group could focus on. And then just general billing education is something that was brought up, I think, by others here as well. I would summarize that as like how to finance integrated care and how to think about financing integrated care could be a educational effort that the group undertakes. And then finally, and this may be a place where, Andrea, you can talk to a little bit more specifically with Resilient Georgia, political will. How do we engender political will for the varied number of things that we've all talked about today that eventually end up being on some level legislative or regulatory in nature? Yeah, so those are the things we talked about as possible foci for a future work group.
Thank you, voluntold person. Were there any additions to forming a work group from outside of the work group? Anything that we need to add to the list?
I would like, if possible, to ask folks in the chat. You've had this experience here today. How likely are you to join a work group? So this would be an action-oriented group that gets together on some regular basis of some sort, right? So we'll do a little motivational interviewing strategy here on a scale of 1 to 10, 10 being like, I'm there, 1 being, and 1 is fine, by the way. People are busy, they have time, but 1 being, no, not quite sure. What number would you give as far as how likely you are to join a group like that? Just put it in the chat. And please be honest. We're not going to feel bad about it.
I think, one of the challenges I see when I meet with groups like this is the group of people that is already doing a lot. I'm thinking of April, like, gosh, we would all love April to just be everywhere all at once for us. And she's already doing that. So I think it's okay to know that you maybe can't participate all the time, but you could still be part of emails. You could still read information that we send out. And then those of us who have the bandwidth to meet regularly can facilitate that. It doesn't mean you wouldn't be valued in that process because you can't attend.
Yeah. And
So go ahead. Sorry.
I was just going to ask you, Andrea, also to,
Sure.
I also wanted, actually, I forgot to give David a little space to talk about the PCAs in there. But
Yeah.
before we do that, Andrea, could you describe a little bit about Resilient Georgia's relationships, particularly with the state legislature, which I think would be helpful for the group to hear that Resilient Georgia is a really great platform to have these conversations because of their relationships.
Absolutely. And I won't pretend to be the expert at advocacy or legislation. However, I will say Resilient Georgia began with bringing together folks from DCH, DBHDD, DJJ, all the acronyms you can think of, to form this partnership. And so what has been built along the way is some very strong connections to legislature in Georgia, and also in particular with the Behavioral Health Reform and Innovation Commission, which is really working across the aisles to put forth legislation to improve mental health care and access across the state. And so our board director is Brenda Fitzgerald, who sits as chairperson of one of those subgroups for the Behavioral Health Reform and Innovation Commission. I have met with Mary Oliver, who is the chair of the workforce group. So we have very strong relationships there, and they're seeking information from Resilient Georgia about what to focus on in those recommendations. We also have a really great relationship with a Georgia mental health policy group that was recently formed a few years ago that has over 70 advocates from various organizations across the state who are coming together for mental health policy initiatives. So Resilient Georgia is a part of that as well. So I think we're positioned very well to take what we're doing here in this work group world that we're talking about, and really translate it into action items that can be added to legislation through the commission's work.
Thanks. That's awesome. And I don't recognize half of those acronyms, but I assume the rest of you are much more familiar with those. But yeah, it's just to show you that I think we have a unique opportunity here, where this is actually part of the state's agenda. It's not something we even need to raise. They're looking for feedback. They're looking for input. The work of a work group would be to be very strategic about choosing the winnable pieces of things that could happen, right? And so just to give an example of on the national level, one of the things we've done over the last 5 years has been to really champion the definitions of the models. So that we could stop this smorgasbord discussion that kept anything from happening at the higher levels at CMS. So now it's crazy for me being in this field for 20-something years to finally see it. But now when you see legislation and regulation at CMS level, at HRSA level, they call out COCM, PCBH as models of integrated care. It took a lot of work just to get that language into legislation, right? And in regulation. So now we don't have to work on that. Now we can work on other stuff, right? So that's what a work group needs to do, is target strategically and say, all right, where are the low-hanging fruit? Where can we really inform where the state of Georgia goes? Now, connected to that, there's another big network across the state that I think has been important in other states in driving things forwards, and that's FQHCs. So I want to give David just a second to talk about the PCA as another vehicle for advocacy and for promotion of this. So David, just a few minutes for you before we wrap up.
Yeah. Thanks. I just appreciate taking a few minutes. Again, I'm David Newton. I'm with the Georgia PCA, and several of you guys I have met in person and had the great opportunity to be able to travel the state and continue to go and meet with people in person to be able to try to focus on this issue. And certainly from my travels from the Tennessee state line down to the Florida state line, I have witnessed that you've seen one level of integration. Well, you've seen one level of integration. There really seems to be a huge diversity within definition, within understanding, within implementation, and then of course, if you go and visit, and then you see what really is going on, to see what is promoted, and then what is really happening. So it's really diverse across the state, as well as integration within the and collaboration within the public sector. I think that within Georgia, to really be able to make some inroads, to be able to have some strong collaboration within the public sectors and the CSBs, is really going to be essential to be able to get some groundwork, because I don't believe there's any organization that's going to be able to do it all. So we have to always partner and work as a team. Thank you.
Sorry, I was typing. I was trying to name some of the acronyms because I realized not all of us know all the acronyms, and that's okay. Well, any last thoughts? Any questions for myself or Naftali or others before we kind of wrap up?
Go ahead, RJ.
Yes, sorry, I didn't see your hand.
This is just a quick question for Andrea. The policy group that you're working with, do you all have a full-time lobbyist that deals with the political critters, or do you all kind of handle that in a committee fashion?
So I'd have to go talk to the group, but I think because there's 70 participating organizations, they don't have one common lobbyist. They may have multiple lobbyists working for multiple organizations. But what that group has decided to do is check their ego at the door, come in together and talk about what they can accomplish together, that they all have the same goal to move towards. So it's very powerful in that sense, that they have that, like, collaboration matters. They have that combined force, which probably behind it does have lobbyists working behind the scenes. I just don't know how many, but I can imagine quite a few, because that's 70 organizations. It was co-founded by NAMI Georgia. So, we know that there's already that piece that exists down at the Capitol. And I love the politicriters. I love that. I'm going to use that, if that's okay with you, sir.
That is quite all right. Feel free to borrow.
Yeah, RJ mentioned another one in our group. It's another probably Southernism that I'm not familiar with as a native Northerner, but what would you say is that goat has two horns, he said. I thought all goats had two horns. Maybe they have more than one horns.
Some goats actually have 4.
Oh, okay. Well, there you go. So,
well, go ahead, sir.
No, I was just going to say, I don't know about you, Andrea, but this has been extremely helpful. Like, as we start thinking about bringing together a work group around this information you've given us today really informs, the direction, the beginning, the starting points for that. For those of you who will continue on, we'll obviously be reporting back to you, Andrea and I. We'll get together on this. Thank you in advance for the effort you're taking on. I always try to remind people that the small things we do, coming to a meeting today, it may seem like, we spent an hour and a half together. What does this do? These things actually matter. Like, they affect real people's lives. Things that we talk about today in this group have those ripple effects of 2-3 years down the line, could result in a family getting access to care in a seamless fashion in a way that they would not have gotten if people hadn't taken time out of their day, even if they're not paid for this particular activity, to make that happen. So thank you in advance for the effort that you'll be making on behalf of your patients and the other professionals across the state.
Yes, thank you. Air
Yeah.
claps or put clap in the chat, wherever. If you want to leave your email address in the chat so we can stay in touch with you, please do so. I'm sure we have a registration list as well, but just in case, that way we can make sure we keep in touch. And I put my email address in there. If you want more time to digest the questions and think more critically about it and get back with me, please reach out. You can also schedule a meeting with me really easily in my Calendly, which I know Neftali is a big fan of Calendly as well. So thank you, everybody. Have a great day. Hope you get back to patients and clients okay, and have a good one.
Y'all take care. Thank you.
Bye,
Thank
Carol.
you so much.
Bye.
Thank you. Bye.